Good afternoon, everybody. I hope I'm no longer on mute. First of all, I want to say that this would have been much better done by our program officers in the vaccine division, but they are completely pressed with the distribution of second doses. They just got the second lot for COVID vaccine. So they apologize. They gave me some pointers to speak to. And because we're short of time, you'll be pleased to know that I don't have as much to say. I really appreciated what was presented by the other speakers who are speaking from a program point of view. So at the beginning of the HPV vaccine launch in Kenya, there's actually a development of this introduction book launch. And they reviewed the current state of cancer knowledge level. And as in across most African countries, we have very high burden of disease. And some previous assessment had found that about 16% of cancer deaths in 2012 are from women, and we have 7 women dying from cervical cancer in Kenya. We have very low screening rates, and I think Dr. Karuga can speak very well to the National Cancer Strategy, which notes that our screening rates are as low as 16% for the age of 30 to 49. And in a survey done in 2016, sorry, that's not 97%, 97% of the women in the age range of 18 to 60 did not know what HPV was. And less than 5% of Kenyan women could link HPV infection to cervical cancer. So definitely a huge knowledge gap. However, of reassurance, in 2014 with Gavi funding, we had a very successful pilot study in one part of the country where they delivered vaccine and very successful and very high upticks. The success was so high that actually the ministry was pushed to access more vaccines and extend. So that was more than 90% in the pilot program. I think I was asked, I'll talk about the data I was given on where we are. I was asked to discuss a little bit about the structure of our program. I think across most countries, this is a similar structure. The Division of Vaccines and Immunization is under the Department of Preventive and Promotive Health under the umbrella of the Ministry of Health. It carries 3 arms of policy, directive, advocacy, and training, which undertakes advocacy and training and management of the data. Then they have another arm which has commodity security and quality assurance that takes care of the central store and cold chain management and administration. Now, what has happened in Kenya is that we are now a devolved government, and policy and directives are done centrally at the division level. And then at the county level, and Kenya has 47 counties, is where the rollout happens and the actual work. So they need to be involved during rollout. The vaccine launch was done in, I think it was 2017 or 19. But similar to Tanzania, where Mama Suluhu took the leadership, our president, Uhuru Kenyatta, went to the coastal region and launched the vaccine and gave it a lot of support. We have a lot of agencies who are major stakeholders. And of note for this vaccine, there's a lot of involvement of religious leaders. We had a lot of media briefing, a lot of pamphlets and education materials, sessions on television and radio speaking to the vaccine. But this was at the point of the launch. And I think of note, this ceased after the launch. And I understand it's a lot to do with resource allocation. So those community and school outreaches from the county level. And the proposal from the beginning was to have a school-based delivery program because of cost. As mentioned by our colleagues from TZ, that the school-based program was assessed to be a lot more expensive. However, over time, several counties have started doing some level of school delivery. So advocacy was done by our multiple stakeholders who still do some of this work. I've mentioned the media and the leaflets and the TV and radio, and cancer survivors who are involved in the community outreach and speaking to the vaccine. And actually the first girl to receive HPV vaccine in Kenya is the daughter of a cervical cancer survivor. So this is the data I have received lately. that currently we have about 228,572 girls who've received one dose. And our program targets grade 4 children who are roughly around the age of 10. Our program doesn't want to precisely say that the girl must be 10. So it's just roughly children who are in that school grade. 2 doses is only 111,000. So you can see we're not doing as well. Now, when I looked up data of children ages 10 to 14, we have about 4,000 million in that age range. So I imagine one age range would be 1,000 million. So we're still very, very far from being where we need to be to achieve the coverage that we desire, even for the single target grade vaccination program. And let me see what else I've been told. So we've done the survivors. So the lessons, major lessons learned is the need for sustained communication and engagement, wide engagement with stakeholders. And although the education sector was heavily engaged, we still need a lot more community strategy so that we ensure parents are encouraged to present children. And previous work before the vaccination was noted, we had a lot of myths and misconceptions. At one time, we had a lot of letters from people, doctors with religious alignment who, I think this has been seen over around a vaccine hesitancy and say that the vaccine causes over, I think was 300% infertility, things which absolutely make no sense. In a pilot in Eldoret, they found that though 88% of the mothers say they vaccinate their children, when the vaccine was presented, only 33% are vaccinated. There are issues that have been presented about challenges even with clinic delivery. There are issues of road access, the days, as was mentioned, convenience, and transport. So I think we'll still need multiple strategies if we want to achieve coverage. When schools are closed, it becomes difficult. This was also mentioned. And when the COVID vaccine happened, schools were closed for almost a year. And the HPV vaccination suffered a big blow with very low coverage of up to only 30% for the first dose in 2020. So currently the program is planning to ramp up outreaches to ensure vaccination of girls ages 10 to 12 years old and expand vaccination to 13 to 14-year-olds this August. Yeah. And the target for the year then will be 700,000 girls. Of note, there's one county out of the 47 in Northeastern where they have very difficult road networks who haven't vaccinated a single girl. Otherwise, I think it's good to say that all other 46 counties have initiated vaccination. So I'd like to acknowledge our HPV program officials who were not able to attend, but gave me some of the information that I've shared with you, and thank all of you, the audience, for listening to me, and really appreciate listening to the other program officials from the other countries and congratulate them for the work that is done. Thank you.